A very good morning to all. So I'll be speaking about etiopathogenesis of CSR. So it's actually a multifactorial condition, and it's basically a complex interaction of known and unknown environmental and genetic factors for the same. It's a very poorly understood entity. So there are a lot of theories which have been proposed for the same etiopathogenesis. It's a choroidal theory, the RP theory, the choroidal and the RP dysfunction, that is a combined theory, the hormonal factors, the genetic factors, and the cytokine analysis. So coming to the role of choroid, that is basically starting from the stasis, ischemia, and inflammation. We have increased hydrostatic pressure in the choroidal layers, and with increased hyperpermeability, which further lead to evolution of PEDs and further release of SRF in the subretinal space. So this was supported by a lot of people like Gass, Gaia et al. And Prunty and Flammer. The Gass had proposed that it's a focal increase in the choriocapillaries permeability was the primary cause. Again, on ICGA, there was hyperpermeability seen at the level of choroid, which was kind of an evidence for this choroidal theory. Prunty and Flammer, again, they noted dilated vessels and delayed filling in the FA, ICGA and SLO, which was suggestive of localized lobular inflammatory and ischemic choroiditis. Few more people have supported the choroidal theory, like Hayashi et al., which they proposed choroidal ischemia being the main cause. And Little et al., again, they had proposed the choroidal blood flow autoregulation being the cause of in chronic CSE. Ijema et al., again, proposed a thrombotic mechanism which was responsible for the same. So this was kind of an evidence which for the choroidal theory, that is hyperpermeability at the level of the choroid. You can see in ICGA there is a clear-cut hyperpermeability of the choroid, and with clear-cut leakage seen. Again, an evidence for the role of choroid is seen in the OCT pictures, SC OCT pictures, in which we can see the thickened choroid as per denoted here. Coming to the role of RP, that is the second theory. It's because of any undefined insult, the RP can be kind of degenerated, and which may not have a proper role of a choroid here. So that RP, we call it in clear term, that is a sick RP syndrome, or another term used is DRPE, that is diffuse retinal pigment epitheliopathy. So this is because of the pigment retinal pigment epithelium that the SRF accumulates in the subretinal space. Again, a lot of people supported this, that like Spitznaz, Nagy, Marmer, and Marmer. However, Spitznaz and Nagy, Marmer were kind of opposite to their theories. Spitznaz supported the fluid movement towards the retina, which happens actually in CSR. However, Nagy, Marmer, after the laser therapy, they proposed that the fluid moves towards the choroid rather than the retina. So there was a controversial statement here. So Marmer again stated that diffuse RP metabolic dysfunction and the focal RPD can overload the system, which is responsible for the chronic CSR. So here we can see the evidence of the role of RP, the clinical picture which shows RP regeneration, and an autofluorescence picture which shows again the RP hypo-autofluorescence, which is supposed to be again mostly commonly seen in chronic CSR where RP degenerates, and we have this kind of a picture. So this was an OCT evidence for the role of RP. That is, we can see there was a complete absence of the RP layer in the below the subretinal fluid, and again coinciding with the clinical picture. So to remember, the RP abnormalities are nearly present in all asymptomatic, even in fluid-free contralateral eyes. And RP damage is not necessarily a late sequel of CSE, but even can occur in forms such as form, that is a preclinical form. So the combined RP and choroid theory, that was again something, it involves both choroidal and the RP disorder. So the choroidal, again the hydrostatic pressure, increased hydrostatic pressure and leading to PEDs formation along with RP disorder. Again, the hormonal factors, very important. There's many components of the hypothalamus, pituitary, adrenal axis and the autonomic nervous systems are responsible for the pathogenesis. In this, hypothalamus pituitary adrenal axis is responsible for the release of the glucocorticoids and mineralocorticoids, and the sympathetic nervous system increase the stimulation of release of epinephrine, norepinephrine, which are responsible for the further responsible for the CSR. So the glucocorticoids and serum catecholamines are basically elevated in CSR, but however, like with the treatment of patients with the symptomatic agents, that was not seen. So it was maybe proposed that it was the catecholamine level was increased because of the increased level of the steroids in the serum. Hormonal factors, glucocorticoids, they are basically genomic and non-genomic. Genomic effects definitely have the effect on, that is the expression of the alpha-1 beta adrenergic receptor genes, which further helps in the increase in the number of the receptors of the alpha-1 beta adrenergic receptor. And the non-genomic are basically, they have ion channels and neurotransmitter receptors as a mechanism. And this, Jampal et al. Supported this with a high dose of systemic steroid. They noted some serious retinal detachments. Glucocorticoids, they have playing a role in affecting all the three layers. That's the Brooks membrane, RP barrier, and the choroid barrier. So it supports basically all the three theories. Again, role of corticosteroids was supported by a lot of people like Hamovicki et al., Jampal et al., and Carvalho-Ricci et al. So we can see Hamovicki et al. Had elevated 24 hours urine cortisol and tetrahydroaldosterone levels. Again, Jampal et al. Supported with that corticosteroid might sensitize the choroidal blood vessels and the RP. And Carvalho-Ricci et al. Used 52% patients in their series with acute CSC had used exogenous steroids within 1 month. So that was the supportive evidence of corticosteroids. Coming to the genetics, again, numerous reports have been there for the familial CSC. And Wienig et al. Has supported this in their series noting 52% families of chronic CSC. It was seen, higher prevalence was seen in the white, Hispanic, and Asian patients. As a cytokine analysis, there was nothing detected in CSR patients like VEGF, interleukin 6-8, interferon gamma, and tumor necrosis factor. Coming to the associated features, we have some kind of a punctate precipitates or white material which is there in CSR patients, where we can see here in the clinical picture as well as the OCT picture, very few opacity seen in the subretinal space. And then this was basically seen in 65% CSR eyes and was the accumulation of shed photoreceptor outer segments elongated in serous detachment, or accumulation of fibrin and lipid, or the macrophages which help in clearing the subretinal space of this debris. So this is the proposed thing for this subretinal precipitates. Coming to the risk factors, so we have psychosomatic factors, that is type A personality. So it's like most patients at risk with 4 to 40 times elevated levels of catecholamines and corticosteroids respectively, going to the proposed mechanism of choroidal or RP theory. Then again, psychosomatic factors like an acute stressor will precede the onset of CSR by a week, or minor stressors preceded many recurrences by hour. So we have like pain, bankruptcy, loss, and just divorce may be a kind of controversial thing which we. So next is role of corticosteroids. So both endogenous and exogenous are responsible, and endogenous being noted in the Cushing syndrome, pregnancy, stress, and rate of CSR in endogenous hypercortisolism reported is approximately 5%. Among the exogenous steroids, we can see CSR being there in treatment of many ocular and systemic diseases with steroids, like ocular like AMN, optic neuritis, solar retinopathy, scleritis, etc. And systemic diseases like asthma, allergic rhinitis, sinusitis, where we used external corticosteroids. And the time of onset of CSR is generally between 1 and a few months from commencing steroid use, but no lower limit has been given for this dose required. So all the form of corticosteroids have been proposed for this CSR, that is oral, inhalational, topical, even intravenous and nasal. Again, exogenous steroids have also been seen to promote, give incidence of 1 to 6% of CSR with high rate of bilateral solid organ transplants, and renal transplant being the major particular at risk because of the underlying renal disease, hypertension, microangiopathy, and also been noted in bone marrow transplantation. Pregnancy, again, it's one of the risk factors which usually it occurs in third trimester and resolve within 1 to 2 months of delivery, after the delivery. So coming to another risk factor, that is Helicobacter pylori, that's a gram-negative bacteria causing gastritis. An infection was noted in a French series of 40% patients in CSC was noted versus 25% in general population. With treatment of H. pylori, the time to fluid resorption was significantly reduced in treatment group, just supporting the role of H. pylori in the same. Another risk factor, that is phosphodiesterase 5 inhibitors, that is which increases blood flow and thickness within an hour. However, with cessation of the medication, the CSR resolves in these patients. Just to summarize the risk factor, that is type A personality, there will lot of been case control series and case series for these risk factors and been reported significant for the CSR. That is type A personality, Cushing's, pregnancy, systemic steroid use, collagen vascular diseases, obstructive sleep apnea, antibiotic alcohol use, allergic respiratory diseases, hypertension, psychopharmacological medications, again as I've already covered, Helicobacter pylori and family history. Thank you.